Atrial fibrillation and atrial flutter. Bianca Li, Du, MSU Huazhong, MD, PhD. Basics. This topic covers both atrial fibrillation, AFib, and atrial flutter, AFlut. Description: AFib, paroxysmal or continuous supraventricular tachyarrhythmia characterized by rapid, uncoordinated atrial electrical activity and an irregular ventricular response. In most patients, the ventricular rate is rapid because the atrioventricular, AV, node is bombarded with very frequent atrial electrical impulses, 400 to 600 bpm. AFlut, paroxysmal or continuous supraventricular tachyarrhythmia with rapid but organized atrial electrical activity. The atrial rate is typically between 250 and 350 bpm and is often manifested as sawtooth flutter, F, waves on the ECG, particularly in the inferior leads and V1. AFlut commonly occurs with 2:1 or 3:1 AV block, so the ventricular response may be regular and typically at a rate of 150 bpm. AFib and AFlut are related arrhythmias, sometimes seen in the same patient. Distinguishing the two is important because there may be implications for management. Clinical classifications: paroxysmal, self-terminating episodes, usually 7 days persistent, sustained greater than 7 days, usually requiring pharmacologic or DC cardioversion to restore sinus rhythm. Permanent, sinus rhythm cannot be restored or maintained. Non-valvular AFib, absence of moderate to severe mitral stenosis or a mechanical heart valve. Lone AFib occurs in patients 60 years, with possible genetic predisposition, who have no clinical or echocardiographic evidence of cardiovascular disease, including hypertension, HTN. Epidemiology: incidence/prevalence increases significantly with age. Young patients with AFib, particularly lone AFib, are most commonly males. Incidence: AFib, from 0.1%/year 40 years to 1.5%/year greater than 80 years. Lifetime risk, 25% for those greater than or equal to 40 years. AFlut is less common. Prevalence estimated at 0.41% in general population, with 2.7 million patients in America. Increases with age, up to 8% in those greater than or equal to 80 years. Etiology and pathophysiology: cardiac, HTN, ischemic heart disease, heart failure, valvular heart disease, cardiomyopathy, pericarditis, and infiltrative heart disease. Pulmonary embolism, P, chronic obstructive pulmonary disease, COPD. Obstructive sleep apnea, pneumonia. Ingestion, ethanol, caffeine. Endocrine, hyperthyroidism, diabetes. Obesity. Postoperative, cardiac, pulmonary, or esophageal. Idiopathic. Lone AFib patients with paroxysmal episodes are usually associated with premature atrial beats and/or bursts of tachycardia, originating in pulmonary vein ostia or other sites. Many patients with AFib are thought to have some degree of atrial fibrosis or scarring. This is often subclinical and usually not detectable with current cardiac imaging techniques, but plays an important role in the pathogenesis of the arrhythmia. Autonomic, vagal and sympathetic tone may play a role in triggering the arrhythmia. The presence of AFib is associated with electrical and structural remodeling processes that promote arrhythmia maintenance in the atria, termed AFib begets AFib. Genetics: familial forms are rare but do exist. There are ongoing efforts to identify the genetic underpinnings of such cases. Risk factors: age, HTN, and obesity are the most important risk factors for both AFib and AFlut. General prevention: adequate control of HTN may prevent development of AFib due to hypertensive heart disease and is the most significant modifiable risk factor for AFib. Weight reduction may decrease the risk of AFib in obese patients. Ethanol consumption may trigger AFib in some commonly associated conditions: HTN and other cardiac diseases. Diagnosis: history. Symptoms vary from none to mild, palpitations, lightheadedness, fatigue, poor exercise capacity, to severe, angina, dyspnea, syncope. Physical exam: AFib, irregular heart rate and pulse, frequently tachycardiac, pulse deficit A-flut, similar to AFib but may have regular pulse differential diagnosis, multifocal atrial tachycardia, sinus tachycardia with frequent atrial premature beats, paroxysmal supraventricular tachycardia, Wolff-Parkinson-White WPW, atrioventricular nodal reentry tachycardia of right. Diagnostic tests and interpretation. Although screening with ECG can detect asymptomatic cases of AFib, the U.S. Preventive Services Task Force notes that it has not been shown to detect more cases than screening focused on pulse palpation. Also, treatments for AFib reduce the risk of stroke and all-cause mortality and increase the risk of bleeding, but trials have not assessed whether treatment of screen-detected asymptomatic older adults results in better health outcomes than treatment after detection by usual care or after symptoms develop. 1. A. The ECG is diagnostic, with findings of low-amplitude fibrillatory waves without discrete P waves and an irregular pattern of QRS complexes. There is often tachycardia in the absence of heart rate controlling medications. A-flut. The ECG is diagnostic. Sawtooth F waves are the classic sign, generally best seen in the inferior leads, although ventricular rate may need to be slowed to see the waves. QRS complexes may be regular or irregular. There is usually tachycardia. Ambulatory rhythm monitoring, e.g., telemetry, Holter monitoring, event recorders, is helpful in diagnosing suspected paroxysmal AFib or A-flut and monitoring for recurrence. Initial tests, lab, imaging, thyroid stimulating hormone, electrolytes, complete blood count, 2D transthoracic echocardiogram, prothrombin time/international normalized ratio, if anticoagulation is contemplated, digoxin level, if appropriate, follow-up tests and special considerations, occasional Holter monitoring and/or exercise stress testing to assess for adequacy of rate and/or rhythm control, chest X-ray, CXR, for cardiopulmonary disease, ECG for signs of cardiac hypertrophy, ischemia, and/or other arrhythmias, transesophageal echocardiogram to detect left atrial appendage thrombus if cardioversion is planned. Sleep study may be useful if sleep apnea is suspected. Test interpretation, evaluate for presence of atrial dilatation and fibrosis, atrial thrombus, especially in atrial appendage, valvular/rheumatic disease, cardiomyopathy. Treatment medication. 2 primary issues in the management of AFib and/or A-flut. Decisions on heart rate control, control ventricular rate while allowing AFib to continue, or rhythm control, terminate AFib and restore normal sinus rhythm, and decision to anticoagulate or not. Anticoagulation therapy to prevent thromboembolism, primarily stroke, reduces risk of stroke by about 2/3. Several calculators exist for estimating yearly risk of thromboembolic event, atria, CHA2DS2-VASC. If risk is sufficiently low, or risk of bleeding is high, no anticoagulation may be indicated. Clinical judgment and patient preference remain important. American Heart Association/American College of Cardiology Anticoagulation Guidelines, the same for AFib and A-flut. CHA2DS2-VASC scoring, CHF 1 point, HTN 1 point, age greater than or equal to 75 years 2 points, DM 1 point, prior stroke or transient ischemic attack TIA 2 points, vascular disease 1 point. Age 65 to 74 years 1 point, female sex category 1 point. CHA2DS2-VASC is the recommended stroke risk assessment for patients with non-valvular AFib. In patients with non-valvular AFib and a CHA2DS2-VASC score of 0 in men or 1 in women, anticoagulant therapy may be omitted. 2b. In patients with non-valvular AFib and a CHA2DS2-VASC score greater than or equal to 1 non-sex risk factors, oral anticoagulant therapy may be considered. 2c. Aspirin is no longer recommended for antithrombotic therapy in atrial fibrillation. Unless contraindicated, patients with non-valvular AFib with any high-risk factors for stroke, prior TIA/cerebrovascular accident CVA/thromboembolism, or a CHA2DS2-VASC score greater than or equal to 2 in men or greater than or equal to 3 in women should receive oral anticoagulants. 2. DOAC, direct-acting oral anticoagulant, /NOAC, novel oral anticoagulant, agents are preferred for most patients with non-valvular atrial fibrillation who should receive anticoagulant therapy. Oral anticoagulants include warfarin with maintenance of an international normalized ratio, INR, of 2.0 to 3.0, dabigatran, rivaroxaban, apixaban, or edoxaban. 2b. Patients with mechanical valves should be treated with warfarin to maintain an INR of 2.0 to 3.0 or 2.5 to 3.5 dependent on the type and location of the prosthesis. Recommendation to anticoagulate is independent of AFib pattern, paroxysmal, persistent, and permanent, although ongoing efforts to better understand who may be at greater and lesser risk of thromboembolism continue. Dabigatran, Pradaxa, apixaban, Eliquis, rivaroxaban, Xarelto, and edoxaban, Cevisa, a new factor XA inhibitor are available DOAC/NOAC medications. 2a. The selection of an antithrombotic should be individualized. Consider the risks of each agent, cost, patient preference, and tolerability. Alert renal and hepatic functions should be evaluated prior to initiation of direct thrombin or factor XA inhibitors. 2b. Limited information is available about safety in patients on renal dialysis. Dosing of such agents may in fact need individualized adjustment. Specific reversal agents for life-threatening bleeding are available. Reversal agents are available for some DOAC/NOAC medications. Idarucizumab, Praxbind, for dabigatran. 2b. Coagulation factor XA, recombinant, inactivated SO, and XA, for apixaban and rivaroxaban. 2b. In addition to anticoagulation, initial rate control must be achieved followed by a decision regarding long-term strategy, rate control alone, or rhythm control. 4 classes of medications are available to achieve ventricular rate control: beta blockers, i.e., metoprolol, non-dihydropyridine calcium channel blockers, i.e., verapamil, diltiazem, digoxin, and amiodarone. Optimal target for ventricular rate has not been firmly established, but there is evidence that aggressive control of the ventricular rate, 80 bpm, offers no benefit beyond more modest rate control, i.e., resting heart rate 110 bpm. Preventing rapid ventricular response, RVR, rates using AV nodal blocking medications is also often effective at controlling a patient's symptoms associated with AFib or AFlut. Patients in whom rate control cannot be achieved or who continue to have persistent symptoms despite reasonable heart rate control may require attempts at restoration of sinus rhythm. Ventricular rate control can often be difficult to achieve in AFlut due to the more organized nature of the atrial electrical activity. For this reason, conversion to sinus rhythm is often the preferred strategy for symptomatic patients, and catheter ablation is also considered as a first-line treatment in recurrent AFlut. Restoration of sinus rhythm using electrical or pharmacologic cardioversion may significantly reduce the symptom burden of AFib or AFlut in many patients and may also be useful for controlling ventricular rate. Cardioversion does not impact the long-term risk/benefit ratio of anticoagulation. Cardioversion is most often performed electrically, but may also be achieved using antiarrhythmic drug therapy in some instances, by experienced clinicians. If duration of AFib/AFlut is greater than or equal to 48 hours or unknown, anticoagulate for greater than or equal to 3 weeks before cardioversion to reduce the risk of stroke. Alternatively, once anticoagulation is established, a transesophageal echo may be performed to exclude the presence of left atrial thrombus, allowing cardioversion to proceed. After cardioversion, anticoagulation should be continued for greater than or equal to 4 weeks in all patients in whom duration of AFib/AFlut is greater than 48 hours, as the post-cardioversion period is a time of increased stroke risk regardless of the CHA2DS2-VASC score or the method used to restore sinus rhythm. 2b. B. Randomized clinical trials, AFFIRM and RACE, comparing the outcomes of rate versus rhythm control found no difference in morbidity, mortality, and stroke rates in patients assigned to one therapy or the other. Issues for referral management of AFib or AFLUT refractory to standard medical therapy, i.e., unable to achieve adequate rate control with medication or development of significant bradycardia with treatment, may require the use of more aggressive treatments. These may include pacemaker implantation, to allow for more intensive pharmacologic blocking of the AV node, or an ablation procedure. AFLUT in particular is often very amenable to ablation, thus, consideration should be given to early expert referral in appropriate patients. Antiarrhythmic drug therapy can often be very effective but should be prescribed by experienced practitioners. Surgery/other procedures. Electrophysiologic study and ablation may be considered for patients with either AFib or AFLUT. In the case of AFLUT, ablation is a procedure viewed as a first-line therapy. Ablation of AFib may be reasonable in symptomatic patients with heart failure with reduced ejection fraction, HFrEF, to lower mortality and reduce hospitalization. 2b. Cardiac surgery, e.g., the Maze procedure, ligation of the left atrial appendage, may be considered in patients planning to undergo cardiac surgery for other reasons. A left atrial appendage closure device Watchman may be useful in those at increased risk of stroke and systemic embolism who have contraindications to long-term anticoagulation. 2b. Admission, inpatient, and nursing considerations. Patients with significant symptoms, RVR, AFib/AFLUT triggered by an acute process, e.g., MI, CHF, PE, or in whom antiarrhythmic therapy is being started likely require admission to the hospital for a period of stabilization. Outpatient management is reasonable for low-risk patients with controlled ventricular rates. Acute therapy for symptomatic patients with AFib or AFLUT, 4-beta or non-dihydropyridine calcium channel blockers for control of ventricular rate in patients without pre-excitation. Commonly used therapies in the acute setting include metoprolol tartrate, 2.5 to 5.0 mg for bolus over 2 minutes, up to 3 doses diltiazem, 0.25 mg/kg for bolus over 2 minutes and then 5 to 15 mg/hr. Some patients will be far more responsive to one class of agents than another. For this reason, if rate control is difficult to achieve, switching drug classes may be useful. Urgent cardioversion should be performed in hemodynamically unstable patients. It is somewhat unusual for AFib or AFLUT alone to cause marked hemodynamic insult, thus, the possibility of a concurrent process should be considered in this setting. Consider the initiation of anticoagulation therapy. Ongoing care. Consider elective expert consultation. Follow-up recommendations. Patient monitoring. Adequate anticoagulation levels with warfarin should be determined weekly during initiation and monthly when stable. If NOACs are employed, hepatic and renal functions should be re-evaluated annually. 2b. Diet. Patients on warfarin should attempt to consume a stable amount of vitamin K. Patient education for overweight and obese patients. Weight loss combined with risk factor modification have demonstrated beneficial effects on controlling AFib. 2b. Prognosis. Yearly risk of stroke in untreated non-valvular AFib has declined and now lies between 4% and 5% per year. Anticoagulation reduces the annual embolic stroke rate by about 2/3 for most patients. AFib and AFLUT may increase morbidity and mortality, but the overall prognosis is a function of underlying heart disease and adherence with therapy. Reported risk of anticoagulation varies but lies between 1% and 4% per year for major hemorrhage. Complications. Embolic stroke, peripheral arterial embolization, bleeding with anticoagulation, tachycardia, induced cardiomyopathy with prolonged periods of inadequate rate control. Reference